Good morning, everyone. My name is Theo. I'm going to discuss some of the work that we're doing at the Feinstein Institute for Medical Research at Northwell Health to try to develop and deploy artificial intelligence algorithms. And I'm going to talk about two specific applications, one in bioelectronic medicine and the other one in some point-of-care clinical applications. So I always like to start by acknowledging the people that actually do the work, and I'm here to present it to you. So the members of the Neural Data Science Lab, that are also members of the Division of Health AI at Northwell. We are a group of engineers mostly, but also physicians that are using data from our electronic health record, our own experiments, and of course we're training algorithms based and using this data. The lab is funded by federal and also industry partners. And we have a lot of collaborators. Most of them are medical doctors, chiefs or heads of divisions that are interested in developing such tools and deploying them into their clinics. So I guess I'm preaching to the choir, but the argument of why we need to start looking into artificial intelligence applications in health is, of course, the big promise that these types of algorithms integrating multiple modalities of different clinical data can provide us a better snapshot of a more holistic snapshot of the health of the patient, and that, of course, can help with either avoiding misdiagnosis or avoiding unnecessary procedures, help ordering the appropriate tests, and of course recommend or assist in choosing the right treatments. And right now, more and more AI algorithms have been cleared by the FDA, and the number at this point is 500. The number was back in February. At this point, I've read somewhere that it's more than 800 algorithms that have been cleared with the FDA. And of course, there's the very well-known saying that we keep on reiterating to our medical colleagues, our clinicians, and our nurses that don't worry, AI won't replace you and won't replace doctors, but doctors that use AI will most probably replace those that don't. So, of course, there's a lot of hype and a lot of interest in this field, in the application of AI in healthcare. I always like to set expectations. There are thousands of startups at this point and tens of thousands of publications in various different scientific journals. There are literally billions of dollars invested in this field, but yet there are only a few hundred RCTs, or randomized clinical trials to date. And randomized clinical trials is the tip of the evidence in evidence-based medicine. Whenever you want to convince a medical professional that they should use something, it would be best to actually follow that with an RCT. So that becomes still a bottleneck on how we can increase the number of RCTs on these types of AI algorithms. However, one thing to point out is that, of course, the current technologies are relatively new. With the healthcare AI models, of course, training uptake in other industries such as banking or commerce or entertainment. And that's, of course, because the stakes are a lot higher in healthcare. If an algorithm doesn't work for a platform like Netflix, maybe you're going to watch a movie that you didn't necessarily want to watch. But if a model fails in healthcare, there's the stake of, there's the health of the patient that's at stake. The other point that I always like to make is that while healthcare, understandably so, is slower to uptake these types of technologies, in general, across all industries, AI and ML models that are developed also face a an actual battle in deployment. And there are some statistics out there that mention that almost 87% of developed AI ML models in any industry, they never make it into production. So given that there is a general, it's generally hard to deploy and test these models, and also the fact that healthcare has some more barriers to overcome, it's no surprise that right now we're still trying to push, and this is still a work in progress. One of the things that I would like to mention for this audience is that a lot of the times, especially in computer science, we try to focus on getting that 0.01% better model or 0.1% better model in terms of accuracy, trying to build something extremely innovative. These incremental performance improvements are not necessarily what the stakeholders in these applications are looking for. Based on our experience, if something is 80% or 81% accurate, won't necessarily make a huge difference. What would make a difference is how easily it is deployed. Of course, the importance of the clinical question that we're trying to ask and whether that is relevant to the frontline physicians, the usability of the tool, whether they can easily interact with it, understand it, where it fits into their clinical workflow, how much they trust it, which of course goes back to how well that is validated, and of course making sure that while it works today, it will still work tomorrow and it might work in another hospital. So tracking and monitoring performance drifts. I'm going to start off with our applications in bioelectronic medicine, where we are doing some work that is funded by the NIH through a 3-year grant, and we're trying to reconstruct the anatomy of the vagus nerve. So the vagus nerve is the 10th cranial nerve. It's a very important nerve in our body that runs from the brain and innervates the majority of our peripheral organs. This nerve is consisted of essentially neuronal fibers. It's kind of like, you can think of it as a cable with a lot of smaller cables inside of it. Approximately 100,000 of these. And the way these are organized is very, very important. They travel through the nerve, and these structures we call fascicles. And these fascicles, when go on and form branches of the nerve that go and innervate specific organs. So right now, the vagus nerve is receiving a lot of attention, and it's kind of like at the forefront of bioelectronic medicine because we're building devices that interface with the nerve, specifically stimulate the nerve, to try to treat all kinds of different diseases and conditions. However, we don't necessarily know very well the anatomy of the nerve. So we know some aspects of the anatomy, but we haven't really reconstructed accurately the anatomy of the nerve. So the outcome of that is that existing VNS or vagus nerve stimulation therapies and devices stimulate the nerve as a whole, non-selectively. So they will stimulate all the fascicles and branches that will go to both the heart, the lungs, and the gut, and the spleen, right? So that non-selectivity introduces a lot of side effects and also could reduce efficacy. So there is a need to actually map out these functional and anatomical connections of all these different fibers to where they're going. And as with everything in biology, this is not an easy feat. So I have like this video of a micro CT scan of a vagus nerve. These are the fascicles. These are the important things that we want to track. These contain thousands and tens of thousands of different nerve fibers. And as you can see, this nerve, which is quite long, it's in the orders of tens of centimeters, twists and turns and branches out. And what's even worse is that these fascicles split and merge constantly, and they twist and they change orientation all the time. So it's very important to actually track in 3D the spatial arrangement of these fibers and fascicles, and that is essential to build VNS therapies. As I mentioned, there are many branches that are emerging from the trunk of the nerve, and you can see all the different organs that are innervated by the vagus nerve. That gives us both the big opportunity that lies in interfacing with this nerve. We can essentially affect all these different organs and systems, sense from the nerve to diagnose all kinds of different diseases, and also stimulate it to actually treat them. However, as I mentioned, each of these fascicles has thousands of different fibers in them, and each of these fibers have different properties. Some of them are myelinated, some of them are unmyelinated, and that affects how well we can recruit them with electric current. So we don't want to only track fascicles, but we also want to count and identify each individual nerve fiber inside these fascicles. And that becomes an even harder problem because these fibers are not visible with micro CT scans, so we need to go in and do microscopy and do H&E and immunohistochemistry to stain for specific types of fibers, for myelin and for the neurofilament to identify their actions. So what we've been doing is try to use deep learning to do all these different things. So we've tried all kinds of different models. We've now settled on 3D units as our model of choice to try to track these fascicles in through micro CTs. And by doing that, we can actually recover all these fascicle tracks and track them across many centimeters of the nerve. And not only that, but what that enables us is to draw this almost metro map of the vagus nerve. Essentially, if you can think a parallel of each fascicle being a different metro line or subway line, then we can know where these cross each other and where they merge and then when they split. And that's important information, especially when later on we want to assess the variability of these anatomical features across different humans. And also, it's important to reconstruct because we want to build 3D models of the nerve that we can try out all kinds of different electrode geometries, different parameter stimulation parameters. Of course, I told you that we also need to track not only the fascicles, but also the fibers inside those fascicles, those tens of thousands of fibers. And for that, we're using a variation of a deep muscular CNN, which is trained on the around 50 backbone. It's pre-trained, and we also use some ground truth data, out of which some of them are used to train the model, of course, and some of them are used to validate just to make sure that we're capturing all these fibers accurately. Now, what we first tried, just to make sure that we have a baseline of performance, was some more traditional, let's say, computer vision approaches. So we tried Gaussian mixture models with Voronoi decomposition to try to detect these fibers, and what we saw is that the performance was actually pretty good, but we still had some missed fibers, around a bit less than 20%, and then also some surplus of fibers. And of course, as soon as we switched to deep muscular CNNs, all of a sudden those missed and surplus went down to very, very low values, so we're very happy with the performance of the algorithm right now. And what's important is that for each of these fibers, and for all of them, all 100,000 of them, we can identify their exact location within each fascicle. We can identify the neurofilament, the myelin area, the perimeter, shortest and longest diameter, the myelin thickness. All these are details that are important when you're building a biophysical model of the nerve, so you can see how well, by stimulating the nerve, you're recruiting these fibers, because these are the structures that you want to actually activate. So the pipeline is relatively, it's essentially built at this point, and it's currently running. We're at the second year of this grant. We're going to map out 60 different nerves, 30 left and 30 right vagus nerves from humans. These are cadaveric samples, of course. and we are facing, of course, kind of like a big data, as much as I hate the word, problem, where we're using this, or we have to analyze more than 3 million micro-CT images and more than 4,000 immunohistochemistry and H&E images in a matter of some months. That results to around 200 terabytes of data that need to be moved around within 3 different universities, and all data in our lab and organized. Of course, we're talking about multiple modalities that need to be co-registered and brought together, so it's a rather involved procedure. But at the end, what we're really hoping to do is come up with like a very accurate reconstruction of the anatomy of the vagus nerve that up till now has never been done before. So that's one application in bioelectronic medicine. Of course, we used machine learning in some other things, such as decoding the activity of the nerve, which I'm not going to go through due to interest of time. I'm going to switch over to our projects that relate to bringing these tools to the bedside. And the main application that I'm going to talk about, although we're working on multiple different projects within the health system, is the AI for predicting clinical deterioration and supporting clinical decision relating to clinical deterioration. So it has been reported that when you show up in the AR, there is a certain chance that you might get either under triaged or over triaged. That means that doctors or nurses that make the decision whether you should be admitted in the ICU, in a regular med-surg floor, or sent back home, sometimes don't necessarily make the right decision. That means that some of the patients that show up in the ER and get admitted to the hospital should have been admitted to the ICU. And there are many reasons why they don't. Maybe the ICU is full, or maybe they haven't really shown very obvious signs of their severity of the disease. That's why up to 5%, and that's a nationwide percentage, of patients that are admitted in regular medical wards actually deteriorate, requiring intensive care very shortly into their hospitalization. And that is a problem, of course, because these should have been stable patients, and if they weren't, they should have been admitted to the ICU. So, but that's a fact that happens throughout all our hospitals. And I like this quote by Dr. Patrick Brady that mentions that patients don't suddenly deteriorate. It's the healthcare professionals that suddenly notice. And of course, that's not a jab to healthcare professionals. They're doing the best they can, almost in cases that they're showing amazing heroism in how they're trying to help and treat patients. However, they do need to care for several patients at a time. They need to have in mind both the labs of each patient, the vitals, try to take in information coming from radiographs, from different demographics, comorbidities, medical notes. These are a lot of information, and what they're trying to do is combine all these and try to find these subtle signs of deterioration, which is a tall ask, especially for some of the work healthcare professionals. And that's where we think that AI can play a pivotal role in this clinical workflow. And we are part of Northwell, and Northwell's advantage is that it is the largest health system in New York. It's 23 major hospitals. It's more than at this point it's more than 800 patient clinics. More than 2 million patients in the region are treated in Northwell hospitals, and we have more than 5.5 million patient encounters. That results in a wealth of data, and what's more important is that we are catering to the New York metropolitan area, which is one of the most ethnically, culturally, genetically, socioeconomically diverse population in the US, and I would argue the world as well. So that means that we're not just getting a lot of data, we're also getting data that are very diverse, and that helps us with mitigating bias in our models. So what we do for this specific project, and that's again a funded NIH grant for the next 4 years, and we've just started, is to try to use not only electronic health records of these patients, but also continuously monitor vitals And we do that for medical and surgical, for med-surg patients in these wards by using these clinical wearables. These are continuous monitoring patches that measure things, vitals essentially, things like heart rate, temperature, breathing rate. And all these are sampled every second or every 15 seconds. So these are continuously monitored. We've deployed and piloted 3 different devices in our hospitals. At this point, we have more than 1,200 patients that we've acquired data during the hospitalization with more than 4,000 days of data. Our goal by the end of this grant is to increase that number to 4,000 patients and more than 20,000 days of data in 2 years. And that will essentially provide us with the largest, as far as we know, data set of these types of patients. One of the things that we've worked on is trying to monitor mothers during birth. And that is important because we want to detect reliably when they develop fever. And fever during labor is actually one of the best predictors of neonatal early onset of sepsis. And that is, of course, a major cause of morbidity and mortality for neonates. So it is important to try to predict the emergence of maternal fever during labor. And what we did was use these patches to continuously monitor vital data from 336 women during labor. And that, of course, included heart rate variability because we had access to other intervals from our cardiac measurements. We developed a model that tries to predict the onset of fever. And what we saw is that one of the strongest predictors for that model is heart rate variability. So lower heart rate variability up to 2 to 3 hours before the actual onset of the fever can be highly predictive of the actual fever happening. And that is important both from a physiological standpoint. It is very interesting that heart rate variability, that a lot of people also think that it's a proxy of vagal tone, is involved in and senses the onset of the fever hours before. But also, of course, clinically is also very important because that 2-3 hour window can help the doctors actually intervene and try to stave off fever, which would help a lot the baby. Another thing that we're working on is try to predict clinical alerts of deterioration. In essence, try to predict hard clinical outcomes that are happening in these patients. As I told you, a lot of these patients, a significant number of them, deteriorate while also being in hospital, meaning that they would require elevation of care. When we notice that they require elevation care, that might be actually a bit too late, or sometimes it's not available immediately. So if we need to transfer them immediately to an ICU, that might not be always the case. So we're trying to predict that up to a day before the actual clinical alert that would require elevation of care. So we used, out of these 1.2 thousand patients, 900 to develop a predictive model of this exact deterioration using data from more than 1,300 devices. What's important about this work is that we've tested the algorithm that we produced not only on prospective data, meaning data that were acquired after we built the algorithm, and they were the algorithm was tested in a silent mode, of course, using different patients from a different hospital at a different point in time, using the same patch that the data came from to train the model, but also try to see whether the actual device mattered. Of course, we kind of expected that it shouldn't, and indeed it didn't, meaning that we could use any type of continuous monitoring patch, any type of clinical wearable to deploy this algorithm, and it would still work very, very well. And when we looked at how far ahead we can predict the alerts, we have on average around 17 hours in advance of these clinical alerts. So now what we're trying to do is increase the numbers, increase our accuracy, and make sure that we're developing the best algorithm for this use case. I'm going to wrap up with one last thing. Another feature that we're trying to add to these predictions is that we want to not only tell the clinician that somebody is at risk of deteriorating shortly, but also what is the underlying phenotype of deterioration. People deteriorate for all kinds of different issues, cardiac, renal, respiratory. We want to make sure that we can provide them with some added information, not only that this person deteriorates, but also why. And we're using unsupervised clustering for this to detect distinct clinical phenotypes. We've applied this in COVID, and one of the things that we saw is that we can actually do this dynamically, so we can track these phenotypes throughout the pandemic and see how different these phenotypes are for different strains of the virus, for different waves of the pandemic. And we found some very interesting things that were recently published, but the most important thing is also that we can track these for an individual patient. So while during hospitalization and while they're going through the clinical trajectory, we can actually at any given time tell and assign them with a dynamic membership of these phenotypes. And I'm done, so thank you so much, and any questions?
Okay, I think we have time for one question, so anybody? Can you predict A2?
So, in principle, yes. The idea there is that, of course, there are algorithms that are tailored to predicting AFib events. Currently, we're working on a separate project with Bioelectronic, with an industry sponsor, to try to predict heart failure admissions in advance. And part of that is to actually try to predict AFib events and then predict heart failure admissions. So there is ongoing work, not only by us, by a lot of different people, to try to predict these events.
Thank you very much.